session. I want to welcome everyone. I'll try to do it individually, but bear with me. We have a lot of people from the network joining us, which is what we like. So we have people from Chilenge Level 1. If you hear me, just wave so that we know that you can hear us. So Chilenge, we have our colleagues from Kalabo. We have people from Mongo District Hospital. Thank you so much. We have people from Monze Mission Hospital. We have people from Muzei Rural Health Center, Nyimba District Hospital, St. Francis Hospital, Senanga Urban Health Center, Shampande, Chipata. We have people from Chimunsi Rural Health Center, Litambia, people from Chifundo.
Even Chilanga.
Okay, Chilanga, you're welcome. We've seen you join us. We have people from Petauke, Urban, and we have Sons of Thunder, which is in Kazungula. So this is Sombo, and here in the hub, I have our infectious disease specialist. We have Dr. Klassen Cassidy. We also have some of our HNPs from UTH. We also have some of our colleagues from the Adult Center of Excellence, colleagues from Pediatric Center of Excellence, and we have our colleagues from Vanderbilt University and University of Maryland. These two universities support our infectious disease unit here at UTH. So just a recap about last week, we looked at the HIV program in Zambia, where we are and where we want to be. We need to put more patients on TB prophylaxis treatment, that is isoniazid for now, but we are soon going to move to a weekly one, which is isoniazid with rifampicin just for 3 months. We need to get our patients suppressed, so we are encouraging the transition of patients to more efficacious regimens, that is dolutegravir containing regimens. As for children, we are transitioning them from all children from nevirapine-based regimens to more efficacious regimens. As for HIV testing, we need to get to that first 90. We are almost there. Let's also use self-testing as one of the modes of catching people with HIV and bringing them into care. We also have to optimize our differentiated service delivery. We are encouraging people who are suppressed on ART for more than a year to go into models of differentiation, which could even be appointments as far as 6 months apart. That said, I'll ask Dr. Vinikoor to just share his screen. I know he presented 3 weeks ago on hepatitis B. He just gave us an overview. Dr. Vinikoor, go ahead and share your screen. An overview of hepatitis B and where we are as a country. It was interesting to see that we have more than 500,000 people living with Hep B, and that's just from one study, the Zamfir. And a lot of people are hepatitis B mono-infected. And of course, we have a group of people that have both hepatitis B and HIV. So he's back today to just give us another dose of hepatitis B. We had an overwhelming response, especially that this really concerns us as healthcare workers. We are at risk if we don't carry out appropriate prevention. So Michael, you're welcome. Please go ahead with your didactic.
Okay, Sambo, can you hear me?
We can hear you very well and we can see your slides, so it's perfect.
Okay, so the cases will come later?
Yes.
All right. And how long do I have approximately?
About 20 minutes.
Okay. All right. Thank you, everyone, for tuning in to this week's EXO session, and thanks to the organizers for inviting me to return. So I'm Dr. Vinikoor. I've lived in Zambia for about 6 years, although I'm American by background, and I'm an infectious disease doctor and a specialist of hepatitis B. And I've been taking care of patients in Zambia for more than 5 years, and just would like to share my experience. So today's session is called Hepatitis B in Zambia, Management of the HBsAg-positive Patient. And for those of you who tuned in 3 weeks ago, I tried to emphasize that in Zambia, the most common hepatitis test that you'll find at your facility lab is the hepatitis B surface antigen test. And that's good because that is the most important test for managing a patient. That gives you the diagnosis, and it also helps you to follow them up. And so if you have a person who has a positive hepatitis B surface antigen, you have to provide further clinical care and management. If the test comes out negative, then the patient can be discharged from further care. Let's see here. Okay. So our learning objectives for the next 20 minutes are to learn what are the basic package of lab tests that you need to manage a person who has hepatitis B surface antigen positive. Number two, to distinguish what an acute from a chronic hepatitis B infection looks like. Number three, to understand why we give antiviral therapy and when should you give antiviral therapy to persons who are what we call HBV mono-infected. These are people who have hepatitis B without HIV. And I know that brings in a lot of confusion. So that's why we focus on number three. And number four is how do you monitor hepatitis B antiviral therapy? So a reminder from Zambia. Zambia was a very important study for people like me who like to treat hepatitis, because for the first time we realized that there are about more than 500,000 people in Zambia who had a hepatitis B surface antigen positive result. And you can see that here. But the second take-home point from Zambia was that most of those hepatitis B positive individuals were actually HIV negative. So I want to take away your discomfort for managing these patients, because I get a lot of calls, and I know my colleagues at UTH also do, about how to deal with these patients and how to manage them in our health system where we have some constraints. So I'm going to teach you the basics that will allow you to do a very good job of managing these patients. And of course, I won't be able to address everything in 20 minutes, but I'll just give you the basic package. So I've set this up kind of in a number of steps. I think there are about 6 steps to managing a patient with hepatitis B surface antigen positivity. So step 1 is HIV testing. I can't overemphasize the need to know the status of the patient. Patients who have HIV and Hep B co-infection, what we call co-infection when you have both infections, they're at very high risk of liver cancer and mortality, and they should be on ARVs as soon as possible. We actually were giving universal ARVs to these patients long before we introduced that for all patients in Zambia. So that's a very important thing, is to make sure that they're on ARVs. And the first line ARVs available in Zambia were purposefully picked because they cover hepatitis B. So you can see that the adult and adolescent regimens, whether they have the new dolutegravir or the older efavirenz, both of the regimens, the red ARVs work against hepatitis. So you have TDF and 3TC in there. And even the pediatric regimens all have 3TC, which covers hepatitis. So if you prescribe first-line ARVs to a client who has HIV hepatitis B, then you are treating the hepatitis B. So that's the first step, is to make sure you're aware of the HIV status. And if HIV is there, they get ARVs. Very easy. Now I'll go on to step number 2. So step number 2 is you need to do some basic lab tests to assess the patient, just as you would for HIV. So you see here these 4 tests in black: ALT, AST, platelets, and creatinine. These are available at, I would say, 95% of primary health centers and above in Zambia. And there's nothing fancy here at all. So with these basic tests, you can do a good job of assessing a hepatitis B patient. So the ALT is important because that helps us know when should we start antivirals. The AST is a test for cirrhosis, I'll tell you about in a minute. Platelets are also helpful for cirrhosis, which is a form of liver disease. And creatinine, of course, helps us to assess the kidneys, to guide when it's safe and when it's not safe to give tenofovir. So what I do in practice is I counsel the patient about hepatitis B, and then I get some basic labs, these 4, and I ask the patient to return for results. If you can get them back quicker than 1 to 2 weeks, that's fine. But basically, I tell clinicians when I'm training them, there's absolutely no rush. So you should get these tests, get the results, and then carry on. You know, don't rush into giving any treatments on day one, unless, of course, they're HIV positive. So how do we use these results? So now the patient has come back to you a week later. The ALT is very important because this indicates that there is damage currently happening to the liver. ALT is the most commonly available marker of liver damage. And one thing which I'm sure most of you have not heard before is that in hepatitis B, we use different thresholds to tell us that the ALT is high. So I know that in most laboratories, the ALT limits are usually 35 or 38 or even 40. But in hepatitis B, we actually rely on a lower threshold based upon data from international research. So in hepatitis B patient, when the ALT goes above 19 in an adult woman, we believe that's elevation, and greater than 30 in adult men and greater than 30 in children. So you will have to memorize these thresholds. So greater than 19 in a woman, that would be over 18, and then greater than 30 in men and in children and adolescents. So that's important to remember. Then secondly, you can use the AST and the platelets to calculate something called the APRI, or the AST to platelet ratio index. And the formula for the APRI, I'll show it to you in a second, but it's also in the 2018 HIV/AIDS treatment guidelines, that green book with the tree on the cover. And this is a non-invasive marker of cirrhosis, which is a sign of advanced liver disease. And then the creatinine is used exactly as we would use it in HIV. It guides us on whether it's safe to prescribe tenofovir or whether you might need to refer the patient. And usually with the creatinine, you can calculate the GFR just as you would in HIV. And if the GFR goes below 50, then you would want to probably think carefully about prescribing tenofovir. So this is the APRI, just in brief. It's a simple formula which requires a phone calculator, a regular calculator, and it gives you a score. So I'm going to give you an example here. If the patient's AST is 100 and the platelets are 80,000, and your lab's upper limit of normal is 40, then when you do the calculation, you get an APRI score of 3.12. And what does the score mean? Well, according to international guidelines from the World Health Organization, as a priority, patients with hepatitis B and cirrhosis based on APRI greater than 2 should be prioritized for antiviral therapy, regardless of other tests. So if the APRI is above 2, this is an indication to initiate antiviral therapy. Okay, so that's step 2. So step 1, you did HIV testing. Step 2, you got basic labs. Now in step 3, you need to make a clinical decision whether you're dealing with acute or chronic hepatitis B. And this is a lot of times, sometimes based on experience, but I'm going to give you the classic presentation. So acute hepatitis B is where usually a patient was recently exposed in the past few months to the virus, and they present to the health, they come to the health facility with symptoms. So usually it's a sudden onset of jaundice, which is yellowing of the skin and eyes, fever, fatigue, and maybe some abdominal pain. And this usually develops quickly. So if you ask the client, when did this start? They'll say in the last few days or maybe a few weeks. But they won't tell you this started years ago. Usually they're presenting urgently to the doctor. And when you do the ALT and you get the results, the ALT is very, very high, more than 500, which would be more than 10 times normal. And then the other thing to remember is that in acute hepatitis B, the surface antigen actually becomes negative and clears within 6 months. So that's a definition of acute infection. In acute infection, there's a robust or strong immune response. That's what's generating the high ALT and the jaundice. That's the body fighting the infection off. And actually, although that seems worrying when you're a clinician or a nurse and you see a patient, you should actually be reassured. This means that the patient's immune system is very active and it's fighting the virus. And 95% of the time, it actually succeeds in clearing out the virus, and that hepatitis B test turns negative at 6 months. So the typical presentation we see at UTH in Clinic 5 in outpatient, it's oftentimes a young adult who comes in, and someone who is probably sexually active. And the reason for that is that young adults in Zambia were never vaccinated against hepatitis B, and they tend to have more exposures to sexually transmitted infections. And so most of the cases I see are in young people in their 20s or early 30s who are presenting exactly like this, with yellow eyes, fever, and a very high ALT. So now, what does chronic hepatitis B look like? Chronic hepatitis B is usually silent for a long, long time, and it's oftentimes found when the patient incidentally gets tested. For example, because they went to the blood bank, or they went for medicals, or their health or their job asked them to do the test. Or it could develop, or they could be found when they develop chronic liver disease. So in chronic hepatitis B, the ALT is often normal or is elevated up to about 200. I almost never see an ALT in the 500 and above range in chronic hepatitis B. Sometimes they have jaundice or yellowing eyes, but a lot of times it's very mild and subtle. The symptoms are very subtle, and they may be present for years. So chronic means it's been there a long time. Even if a patient presents with ascites or the typical liver disease picture, if you interview them carefully, they'll tell you that's been going on for a long, long time. So that gives you a hint that this is definitely not acute hepatitis B. In acute hepatitis B, you usually don't see the picture of ascites and a small cirrhotic liver. It's usually rapid in onset. And the other notable thing in chronic hepatitis B, if you're not sure, is that if you retest the patient 6 months later, they will remain positive on the hepatitis B surface antigen test. So in step 3 of a patient management, you need to make a decision whether this is acute or chronic. And if you're not sure, you can monitor them with lab tests, and you can retest the hepatitis B at 6 months if you're not sure. But if you think that for sure this is a classic case of acute hepatitis B, the treatment is almost always just supportive care. Although I know that's difficult because the client feels sick and they have yellow eyes, and you as a provider may be worried. But I can tell you that antiviral drugs, i.e. tenofovir or tenofovir lamivudine, which is available in your facility, they're not harmful in this case, but they're really not recommended because, as I said, there's a natural immune response that clears the infection 95% of the time. And we actually see that only 1% of people develop complications of hepatitis B. Those complications would be liver failure. And in those complications, you would need to refer the patient to a referral center in your province. So if you have a case of acute hepatitis B where you're worried about liver failure, you should refer the patient to a higher level of care, not try to manage them yourself, usually. And now you might be wondering, well, what makes it liver failure? How should we know when a patient is developing liver failure? Well, I put in 2 examples here, which are, I think, easy for most of us to recognize. Hepatic encephalopathy. So this is when the patient has increased sleepiness, inattention, inability to understand. So we're talking about a patient who 2 weeks ago was completely normal, and now they're sitting in front of you probably with their relative, and they're acting confused, and they have acute hepatitis B. That should worry you if the patient is acting very confused. Secondly, bleeding, because as you know, the liver creates clotting factors. And so if the patient is having frequent bleeding, that could indicate that they're starting to go into liver failure. So I would say if you notice these two signs when you're talking to the patient, this should worry you and make a referral. Otherwise, I think you can reassure the patient that 99% of the time they will make a recovery, and what your job is just to monitor the ALT and make sure it's improving, and avoid any other liver injurious drugs. For example, if you're giving TB treatment at that exact moment, it might be worth pausing that. Or if the patient is taking other drugs which could have harmed the liver, it might be worth pausing that. the patient drinks alcohol, it's a good time to stop drinking. And then once the patient makes a recovery, which they will, you do want to see them back at 6 months to confirm that now they've become negative. Because if they remain positive at 6 months, you can now inform them that now they have chronic hepatitis B, and we'll go on to what to do with that, about that. So step 1 was HIV testing, 2 was labs, 3 was acute versus chronic, and now step 4. This is the one maybe most new for some of you. So HIV relative to hepatitis B is more straightforward because we know that without treatment, the CD4 goes down, 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 down in HIV until the point of full-blown AIDS. But hepatitis B is much more complex because you can just see from these lines that the viral loads and the ALT levels fluctuate over the patient's disease course. And what you have to do as a clinician is to prescribe treatment when there is one of 2 things present, either cirrhosis or persistently elevated ALT. If you don't have cirrhosis and you don't have persistently elevated ALT, then you do not need to prescribe antivirals for hepatitis B. So this is an important slide. So most hepatitis B mono-infected Zambians will never actually need antiviral therapy. This is something which you probably haven't been taught very well so far, because I get a lot of referrals of patients who are started inappropriately on antivirals. So just remember, most of these patients actually will not have cirrhosis or persistently elevated ALT. So most will not need antivirals. Second, there's usually no urgency. It's different from HIV where we want to test and treat as soon as possible, as soon as it's safe to do it. In chronic hepatitis B, it's a chronic disease and there's no urgency to start antivirals there and then. It's better for you to take your time, establish counseling, health education, do your testing, and figure out whether the patient has one of the 2 indications for treatment, i.e. cirrhosis or persistent ALT elevation. Just remember that if the ALT is normal now, you still need to follow them up because some patients, as you see from this slide, they will develop high ALT at a later time. And then the final point, which came out of my own personal practice taking care of these patients, is when you're about to prescribe antivirals, it's a good idea to recheck the HIV status again, because I have had at least a couple incidents where I did the HIV test probably 3 to 6 months earlier. I got my results, and now I was ready to prescribe HBV treatment. And sure enough, they became HIV positive in that short window period of time. And so I accidentally even prescribed tenofovir lamivudine to patients who had HIV by mistake. So it's very important that you almost treat these patients like you would in PrEP by giving frequent HIV testing, and make sure before you start HBV therapy that they're HIV negative. So as I just said in the previous slide, most clients will not need antivirals for hepatitis B. This is experience from Dr. Sinkala, Dr. Nsokolo, Dr. Kelly, and I from UTH. We actually followed very intensively about 120 patients for 2 years. We did their ALTs and ASTs every 3 to 6 months, and we gave them transport so that they would come back for all these visits. And what we found was, if you look at the dark boxes, only up to 23% ever started antivirals. All these light gray boxes, they never qualified because they never had cirrhosis and they never had that persistently elevated ALT. So even if you follow them up for some years, you'll still see that only a fraction need antiviral therapy. So if you want to prescribe antiviral therapy, what does that mean exactly? So there are 2 drugs which are considered the most potent, tenofovir DF or TAF, which is coming in very soon into Zambia. It's a new kind of tenofovir, and entecavir. These are very potent against hepatitis B, and and drug resistance does not develop against these drugs, which is why they're very preferred. But lamivudine and emtricitabine are also effective against hepatitis B. So those are alternatives. However, drug resistance can develop on these drugs. So in Zambia, our preferred is to give fixed dose combination of tenofovir DF plus lamivudine, or TDF plus 3TC. The reason this is our preferred is that we purchase a lot of it. It's available in pharmacies. We have a very strong experience with its safety and patient side effects and experience with this drug. And you can use the same dose as is provided for HIV. So I believe in almost every pharmacy where you treat HIV, you should have some of this available for your hepatitis B clients. And then point number 4, when prescribing this, you need to counsel the patient that this is lifelong, and I'll explain why in a second. Step 5 is monitoring. Now you've given tenofovir lamivudine combination therapy for hepatitis B. Just like HIV, we would do a short visit, typically at 2 to 4 weeks, to check on adherence and side effects and reassure any information you gave. And then you monitor the ALT. So the ALT is going to be your best friend when taking care of hepatitis B, because since you had a client with high ALT, now you can monitor that the ALT is normalizing on your treatment. So that will give you reassurance that it's working if ALT is now reducing. Also, you would want to monitor the hepatitis B status every year to see if that clears, and you would want to check HIV every year. So if the client was initiated because of persistently elevated ALT, then getting the ALT down to the normal limit, meaning less than 19 in women, less than 30 in adults and children, that's your goal. And then the second goal of prescribing treatment is to help clear up the surface antigen test. However, that one is rarely achieved. Unfortunately, only 1% to 2% per year will achieve that. So that's why I say lifelong, because even if you take it for 20 years, you still only have about a 20 to 40% chance of clearing. So when is it okay to stop? Well, this is from the package insert for Viriad, which is the tenofovir DF tablet. So if you look at the package insert, they actually warn you about a flare. Flare means different things in hepatitis, but in this case, what I'm referring to is if the patient were to stop their hepatitis B treatment suddenly, they may experience a rebound of the virus in the body that could lead to severe liver damage, even liver failure. And there are some case reports where this was even lethal. So it's important to tell the client not to stop suddenly. However, before I scare you, I just want to also say that these usually happens when the patient has advanced liver disease such as cirrhosis. And we don't have any data on this in Zambia to know how frequent it happens. So what happens though in the real world? So of course, we know our clients do stop their treatment for various reasons, maybe structural factors or medication belief factors. They do stop. And so it's just important that you know that the patients who have cirrhosis, those are the ones who can get a very bad hepatitis flare if they stop suddenly. So that would be one group you would not want to stop therapy ever. But if the patient is fortunate enough to clear the hepatitis B surface antigen, and I don't care if it happens after 1 year, 2 years, 5 years, or 10 years, you can reassure them that now they've cleared up and you can go ahead and stop the antiviral therapy and continue to monitor that it remains clear. However, this is a rare thing in my experience. If a patient comes to you, which will happen, and says, I stopped my treatment or I ran out of medication, if they're ready to go back on the medication, just go ahead and restart it. Or if the patient is challenging you about the need for antiviral therapy, you could go back to step 2 and do labs and reassess their need for antiviral therapy. Both of these approaches are okay as long as they're not having any severe liver injury at that time. So in my experience, once we start tenofovir, lamivudine, we rarely ever stop it. So now I'm reached my summary. So remember, step 1 is HIV testing. Step 2 is basic labs, which are available in every facility. Once you get those back, step 3 is comprehensive evaluation of the patient, now with the labs and the clinical, the physical exam and the history. And you make a decision on whether you think it's acute or chronic. If it's acute, you're probably just going to do supportive therapy and monitoring. And then if it's chronic, you go on to step 4, and you do initiate antivirals if the patient has cirrhosis or persistently elevated ALT, one or the other of those two. And that will tend to occur in about 25% of patients, let's say. If they're not eligible on the initial review, they don't have cirrhosis, they don't have persistently elevated ALT, you just monitor them to see if they develop indication later. Step 5, if you've already initiated therapy, you monitor ALT, and I recommend maybe 3 to 6 month monitoring. And then in step 6, you also monitor hepatitis B surface antigen to see if it clears up. And of course, on a yearly basis, you also want to repeat HIV testing, and you do want to repeat the basic set of labs. So as I was going through this, I realized I left out a couple things. So first of all, what does persistently elevated ALT mean? Persistent, you understand elevation because I told you 30 for men and 19 for women, but persistent means two consecutive high ALTs that occur over at least 3-month interval. So there's no kind of gold standard definition for this, but I would say that you'd want to get them 3 months apart. And the reason for that is you want to know if this is a chronic liver damage that's occurring to the patient or not. Because we know in Zambia there are other reasons for high ALT. For example, as I mentioned, taking TB treatment, that could raise your ALT slightly. Taking alcohol or beer, that could raise your ALT slightly. There are some possible herbal treatments that could raise your ALT. So there are many reasons why ALT could be elevated. That's why it's important to establish whether this is a chronic ALT elevation or persistent. So if I see a client whose ALT is high today, then low, then high, then low, then high, then low, then they never really qualify in my mind for hepatitis B treatment. You need to have 2 ALTs that are high in a row to meet the definition of persistently elevated. Okay, I think I went really quick there, but let me do my summary, and I'm sure you'll have questions. So the key point number 1 was that almost all health facilities in Zambia, in my opinion, have what it takes to manage hepatitis B surface antigen positive individuals. There's really no need to refer most of these patients out as long as you have basic labs available and you have tenofovir available in your facility. And I know that most of you do. So with this training and with some experience, I think that nearly all clinicians can do a very good job with these patients. Number 2 is that acute hepatitis B infection is anxiety provoking for you, the clinician, and for the patient. But usually it resolves on its own, does not require any intervention, and it's really a symptom, it's really a sign that the patient's immune system is strong and will clear the virus naturally. Key point number 3 is that in chronic hepatitis B, only a minority, less than half of the patients, will need to be prescribed antiviral therapy. And remember these thresholds, 19 in women and 30 in men and children. And key point number 4 is that therapy is lifelong. So you will have to do a lot of counseling of the client so that they understand that they're going to be taking this drug for a long time. So let's go on to the polling question, unless Sambo has other ideas. Okay.
Thank you so much, Michael. So we have our first polling question. Sorry? Oh, crap.
Okay.
Okay, it's okay.
Okay, so we're doing number 3. So
it's okay. Thank you for picking that up.
Yeah. Okay. So question number 3. This is based on something I just told you in the last 5 or 10 minutes. So you're about to start antiviral therapy for hepatitis B monoinfection. So which of these is not necessary to document in the file? So this is one of those tricky questions, not questions. So 3 of these are necessary to document and 1 is not necessary to document. So which of these is not necessary to document in the file? A, whether or not there's cirrhosis. B, the kidney function. C, the patient's occupation. And D, that the HIV status is negative. So please vote.
Hi, Michael. Can you see the votes?
No, I cannot.
Oh, you cannot? Okay. I should be sharing it in a bit. So we have a few people that think it's not necessary to document kidney function, 4%. 3% of the people in the network feel it's not necessary to document the HIV negative status. 91% feel that the patient's occupation is not necessary to be documented in the file. Everyone thinks it's necessary to have cirrhosis documented. So they are saying it's 0. No one has voted for A. So I'm going to end the polling. I hope that's okay.
Good. So it seems like almost everyone voted correctly. So yes, A, B, and C are necessary. So you want to make sure you know if cirrhosis is present, whether the kidney function is okay for tenofovir-based therapy, and whether HIV is there or not. Okay, good. So go on to the next one. Which is next, Sambo?
We can do 2.
Okay. All right. So this is a test to see if you understand what persistent ALT elevation is. So which of these clients who I've seen before at UTH, who had their ALT checked 3 different times, which has an indication to start antiviral therapy? Is it A? So only one of these meet the criteria. Is it A, a 27-year-old man who has the APRI score of 1.7, ALT was 32, then it was 18, then it was 45. B, a 45-year-old woman, the APRI score was 1.8, and the ALT was 15, 14, and then 19. Is it C, 52-year-old man who comes with ascites, the ALT is 28, then 25. D, a 25-year-old woman, ALT of 42, and then 15 and 17. So pick the one who you believe deserves antiviral therapy based on these labs.
We have a couple of votes, but people are still polling. Please go ahead and poll. We have 2 minutes. Even people from the hub are brainstorming for the right answer. Likely they know the right one since they are in the hub.
If the hub gets this wrong, we're in trouble.
I know, right? Only the facilitator shouldn't vote so that there's that, transparency. Go ahead and vote. Which one should we pick? Okay, so I must mention that I'm joined by Maureen. She's one of our HNPs because I was alone up here. And we wish to acknowledge that we've been joined by about 9 more sites: Chadiza, Macha, Lundazi, Mulamba, Nangongwe, Mongu, Chipata, Senanga, Yeta, Chivuna, Ndola, Mazabuka, and Namuseche. This is just buying some time for this. I'm giving it a bit more time. Okay, so I'm gonna send the results to Michael. Okay. So Edgar, please, we can only see the ceiling. You'll soon be sharing your screen. Okay, so there are your results, Michael.
Oh, wow. Okay. So let's
Do you
see
want to
here.
go through each of them and see why you don't think it's A or B or C or D?
Yes, sure. So the correct answer is actually C in this case. And now let me explain why. So remember what I said, in a male, which would be A is a male, you would think about the ALT level of greater than 30. And remember, it has to be persistent, meaning 2 in a row that are more than 30. So this 27-year-old had an ALT of 32. However, it dropped to 18. And then it came up to 45. So he has a fluctuating ALT. He doesn't have persistently high ALT. Because that 18 makes you think that maybe he's intermittently drinking alcohol, or maybe there's another thing that's causing the ALT to go up. It's not hepatitis B.
So it's fluctuating, isn't it? And some of it is even less than 19. And then the APRI is below 2.
Correct.
Yeah.
Now let's talk about B. So B is a woman. So you would, again, now you'd be thinking about an ALT of 19. And so you can see that the client had an ALT of 15, 14, and 19. So none of these were elevated. And as Sambo just said, APRI is less than 2. So no need for antivirals. Now let's go to D next. So in D, this is a woman. So again, you're thinking about 19 as your threshold.
Michael. C. Oh, where did it? Oh, sorry, D.
Yeah, I was just explaining that in D, your ALT is 42, 15, and 17. So the first one is high, I agree. However, it wasn't persistently high, it dropped. Therefore, no need to prescribe antivirals. The reason that C is correct is because of ascites. I don't know if you remember, but there are 2 criteria to start treatment: persistent ALT and cirrhosis. And cirrhosis is usually manifest with ascites, which is the bag of water in the abdomen. And I know you can all recognize this when a patient walks in with ascites. So if a patient has ascites, which you believe is due to cirrhosis, which it usually is, that would be an indication in itself for antivirals. So it doesn't matter what the ALT is at that point because they've met the criteria. So very good try. This is hard stuff.
So what you're saying is if someone has cirrhosis, as sometimes evidenced by fluid in the abdomen, also known as ascites, regardless of what's happening to their ALT, as in this case, you can see for this man, it's sort of dropping, but the fact that he has ascites means that he's eligible for treatment. Am I right?
Exactly.
Okay. Thank you, Michael. We're going to 1 now.
There's number 1. Okay, let's see. All right, so here's the acute hepatitis B case for you. So this is a 22-year-old female university student. She was in previously good health, and now she presents to the health center with yellow eyes, the fever, and it all started in the last 5 days. On your examination, she doesn't have a large liver. She doesn't have any ascites, but she has some lesions noted in her genital area. You collect blood, you do some basic tests, and ALT comes back very, very high, 1,120, very high ALT. The hepatitis B comes out positive, the HIV is negative. So which of the following 4 factors is suggestive that this is acute hepatitis B? Is it A, that the person is a university student? Is it B, because of a very, very high ALT? Is it C, because of the young age of the person, or is it D, because of the genital lesions? Which of these four should most strongly make you think this is acute hepatitis B, according to Dr. Mike?
So we have 30 more seconds. So far, 11% of the network feels that it's the genital lesions that suggest that this may be acute. I guess because maybe there's an STI. The young age, no one thinks it's because she's young. A very, very high ALT in the thousands, 82% feel that this may suggest an acute infection. And the fact that she's a student in uni shouldn't make you think that it's acute hepatitis. There's like 0% think that. So I see people have stopped voting, so I'm gonna share that. You can tell us. So there you go.
Okay, very good. So almost everyone got the right answer. So, so out of all these four, a very, very high ALT should make you think this is acute hepatitis B. As I said about 10 minutes ago, chronic hepatitis B, the kind that where you prescribe the antivirals, usually the ALT is not that high. In fact, we have those very low thresholds. So suddenly, I hope everyone is saying, will start to notice when the ALT is 40 or 50, whereas maybe before they weren't surprised. In chronic hepatitis B, the ALT is not that high, but this is acute. And acute hepatitis B can go more than 1,000, more than 500. So that is a giveaway. Now, why did I put that thing about genital lesions? Well, I think it's just to, I'm like a fisherman and I caught a few of you on my hook, because some people confuse herpes and hepatitis. And so herpes is an STI where you get genital lesions which are painful. And in hepatitis B, there are no genital lesions. So although I agree there is a link between that hepatitis B can be sexually transmitted, in this case, the fact that there are genital lesions does not suggest acute hepatitis B to me.
Thank you so much, Michael. We're now preparing for Edgar to share his screen. He has a hepatitis B case. As we are doing that, I think we'll take a few comments from the network. Do you want to stop sharing your screen, Michael? So we'll get a comment from Dr. Cassidy as you stop sharing. Thank you.
Thank you so much, Dr. Vinikoor, for this presentation. For the benefit of the audience, I was wondering if you would like to talk a little bit more about hepatitis B therapy and the intersection of that with HIV pre-exposure prophylaxis. Since we use Truvada for both indications, there can be some complications and possibly some confusion. So I thought perhaps you'd like to walk us through that as well.
Sure. I mean, I actually think that we need to develop a little bit more clinical guidance around this. But as those of you know who are now providing PrEP, a hepatitis B test is a mandatory baseline test for those clients. And if the hepatitis B comes out reactive, you can still go ahead and prescribe your PrEP. But what it means is that when you are ready to stop PrEP, you have to assess the person for hepatitis B treatment, just as I described. So if they have persistent ALT that's high or cirrhosis, in that case, they would need to be on long-term treatment rather than just PrEP. So I think that's the basic message, that make sure it's documented in the file. And if the client goes ahead to stop their PrEP, that again, I think they need to have some further evaluations for hepatitis B treatment at that point.
Sorry, we were off there. So I was just saying that it's interesting in my own practice, I've only had to start one patient on treatment, even if they are hepatitis B surface antigen. And I think that's very important for us to know that we should not panic. We should take our time and try to evaluate the patient, because I don't know, it's very difficult to stop treatment once it's been started, and it tends to be lifelong. As Dr. Michael said, only 2% or even 3% will actually become hepatitis B surface antigen negative. So you may actually be putting a patient on long-term treatment that they don't need. And remember, this treatment will need monitoring of both the kidney and the liver. So we need to be very careful before we start the treatment. Edgar, are you ready for your presentation? We can see your slides.
Yes, Doc, I'm ready. Are you getting me?
We can get you. Are you able to put the... We can see your ceiling, but not you. So just reposition your camera.
I'm using... I don't know if
No, as you are repositioning your camera, Dr. Thomas has something to say.
Hi, I just want to find out, can the APRI score be used in children? If so, what is the cutoff value?
The question is for Michael. So Michael, the question is, can you use APRI? I call it APRI. I totally made that up. Can you use the APRI in kids? And is it the same threshold of more than 2?
That's a very good question. Yes, I believe it's in the guidelines for all age groups. However, I would think that it does not perform as well in children, because possibly the data from which it were derived came from adults. So I would use it. The other thing to keep in mind if you start using this test and you're a clinician, if there's some other reason that the platelets are low, that will, of course, push the score up. For example, if it's a client with sickle cell, or they have another reason to have, a hematological reason to have a low platelets, that's going to drive the APRI very high. So you might then say, am I really believing that this is cirrhosis, or is it just a high APRI? So, so just keep that in mind. But yes, I'm pretty sure that it's also recommended in children.
Okay, thank you so much. Do we have any questions from the network? I was quick to tell Edgar to share his screen because I was worried we wouldn't manage. But do we have any questions from the network before we go in the presentation into Edgar's case? If there are any, while we are in the case, please just type in, because I can see no one has raised their hand. Also, Peter, okay, please go ahead with your question. I'm so sorry we're not going to see each other. I'm sharing Edgar's screen. I was a bit worried it would not share. So Peter, okay, please go ahead and, is this Peter, okay? Please go ahead. I see the hand is up in Petauke. But Petauke is right here and no one is talking.
Okay.
Yeah.
Good afternoon.
Bill, is that you? Hi, Bill.
Hi. Okay, you can see her since you have shared the slide with Edgar. My question is, we are attending to key population. We are screening them for HIV and hepatitis. So I wanted to know, is there any plan for them to get hepatitis B vaccine?
Okay, so the question is, if you are going to screen people and they are part of the key populations, I don't know if Michael, you're there. Are we planning to get hepatitis B vaccine for people that are negative? Because we know their risk is high. I guess that's why we are screening them.
Yeah, I would answer that not anytime soon is the answer. We don't have enough data in Zambia on adults to determine what the role of vaccination is. For example, many people were exposed to the virus when they were young children, but they cleared up. And so they actually have antibodies to the virus, so therefore they don't need the vaccine. But we don't really know what the fraction of that group is. So we have a data gap, and I know that the Hepatitis Task Force is planning to do some surveillance data in the near future. But I don't think there's enough data to motivate having the vaccine for key populations.
Bill, is that clear? Okay, so we have a question from the hub again. Edgar, are you able to stop sharing your screen?
Yes, I am.
Yeah, then I'll tell you when to share it. Thank you.
I wanted to find out, okay, my name is Nsamanyendwa. I'm an HIV nurse practitioner student just here at Lusaka College of Nursing. I wanted to find out, like in a case of someone who has a low creatinine and then they have hepatitis, then again, in the presentation, I noticed that just giving one, either lamivudine or tenofovir, would bring about resistance. It's encouraged to combine the two. But then what do you do if someone has a kidney problem?
Very good question.
And then the other thing is I wanted to know if someone being on antiretroviral treatment would lessen the risk of them transmitting the hepatitis.
Thank you so much, Nsama. You got that, Michael?
Okay, yes, great questions. So hepatitis B and the kidney. So actually, just like HIV, hepatitis B can also cause kidney problems. That being said, I have yet to see a case of a patient with the creatinine was too low for them to be given tenofovir-based therapy. So I think it's probably going to be a rare scenario when you have the GFR less than 50 and you want to give hepatitis B treatment. You might even consider referring that patient to see a kidney specialist. It's that rare. And then the kidney specialist would probably come up with a tailored treatment strategy for that patient, kind of like the way they do for certain HIV patients with chronic kidney disease. So I won't give you a blanket recommendation, but just say that if you do come across a case, remember there's no urgency. You might just want to repeat the creatinine after a month. And then if it's the GFR remains very low, that might be a reason to refer. Now, as for your second question, which is treatment as prevention for hepatitis B, yes. If a person is taking hepatitis B treatment, they're also less likely to spread the infection.
Yeah, because Edgar, please share your slides. So if they're on, please share your screen, Edgar. Thank you so much, Michael. So I guess it's sort of a U is equal to U for Hep B as well. Mm-hmm. If you're on treatment, you should not be transmitting as much as somebody who's not on treatment, which is, it's interesting. Edgar, you can go ahead.
Dr. Sombo, this is Edgar Chisuo, the clinical mentor for Choma and Namwala. Presenting from Livingstone, but a case for Choma Hospital.
Edgar, please go ahead. You can move on.
Yes, so the list of the patient. It was a male, 2 years old, born on 28 August 2018, was brought to the hospital on request of healthcare workers for hepatitis screening 3 weeks ago. After sibling died from suspected hepatitis complication. Was born at 10.
Edgar, sorry, just move closer to your microphone.
Hello, are you getting me now?
Yes, please don't move from that. It's great.
Okay, thank you. Sorry, I'm not able to. You're not able to hear me via the laptop, so I'm using both the phone and the laptop.
Okay, we are very clear now. So.
Okay, so I'll continue. So the patient achieved appropriate milestone for age. Then the under 5 record was up to date in immunization, received 3 doses of Hep B vaccines according to the Zambia HCI protocol. He was HIV non-exposed. Then when it comes to the parents, both are were symptomatic of hepatitis B infection, and both tested positive for hepatitis B. Then both parents were HIV negative. Then both parents were started on treatment on 11 March 2019. That is TDS 337. When it comes to physical examination, the patient appeared well and alert, febrile, not jaundiced. Weight was 12.5 kg, and there was no hepatomegaly or splenomegaly. Then the test at the lab, the analysis, there are test proteins, then the reactive hepatitis B, then ASH was 74.9, ALT 14.5, then creatinine was 68.96. Now we come to our question. This child. Then the second question was, we decided to treat the parents for hepatitis B. Is there anything we should have done differently? Then the last question was, how do we prevent mother-to-child transmission of hepatitis B?
Edgar, thank you so much. Oh, well done. I see you are not sharing your screen anymore. Thank you so much. So I'll summarize that because you were breaking. Essentially, we have a 2-year-old child who was quite happy going about his life until his brother died because they suspected he had Hep B complications. So that triggered the healthcare workers to actually call this family in. And they, Edgar, please stop sharing your screen. So they called in the family and tested a couple of people for Hep B, of which one of those was this child, achieved milestones very well, not jaundice, quite happy with his life, but was hepatitis B. The parents were also quite happy with their lives, but they turned out to be hepatitis B positive. So the parents were put on treatment, but the baby was a bit of a challenge for the team. I must mention his physical exam was normal, but his ALT was 14.5, which is normal. It's less than 30, as we just learned. I think ALT was 74. We are not given parameters of the parents, but essentially this is a family of Hep B monoinfected human beings. Kindly assist us, how would you manage this child? Was it okay for, should they go about the treatment of the parents? They've already started them on Hep B. And how would we have prevented this clearly mother-to-child transmission of Hep B in this household? So there is a question from Dr. Zico before Dr. Vinikoor zeroes in on the case. We can get comments from the network and from the hub. Dr. Zico, please go ahead.
Thank you very much. Can you hear me?
We can hear you, but we can't see you, and that's a problem. Why can't we see you? You need to switch on the video.
All right, I'll switch it on. But quickly, I just wanted to find out what were the reasons for starting the parents on Hep B antiviral treatment for Hep B? What were the parameters that were used? Oh, yes, basically that.
Okay, but you're aware he said that the parents were Hep B positive. You got that right? Okay, so
yes,
Edgar, are you able to answer this? I know you're not the one who did this, but do you know if they got any other tests on parents?
No other tests were done, but the major reason they used was the issue of the parents being positive, and also they were symptomatic.
They were symptomatic or asymptomatic?
They were symptomatic.
Oh, do you know what symptoms they had?
Yes, the mother presented with abdominal pain. Hello?
Yes, we can hear you.
Yes, the mother presented with abdominal pain. Then also there was vomiting and loss of appetite. When they discussed as the clinical team, they agreed that because of the symptoms which were there and the results, then the patient should be started on treatment. Then for the child, since the child was asymptomatic, although the results were reactive, was not started on treatment.
Thank you so much, Edgar. I don't know if you got that, Zico. So apparently the parents were symptomatic. However, the symptom that Edgar is mentioning is abdominal pain. He doesn't say anything about the lab. Do you want to comment on that?
Okay, I think Dr. Vinikoor was very thorough in his presentation on the criteria for treating with antivirals in Hep B infected patients. For instance, if the patient had trunk ascites, probably that would have been justifiable in a patient who has Hep B surface antigen positive. But without that, I think, like he said, it's not supposed to be an emergency to start antiviral treatment in patients who have not been thoroughly investigated. So maybe without adequate information, it wasn't justified to start treatment in the patient.
Okay, thank you so much, Dr. Zico. So the take-home message is that when we are starting, we should be, there's a lot of layers to it. It's not just the surface antigen. But I'll be very honest, as a frontline worker, this information is not really emphasized on. So I totally understand why people would panic at a positive Hep B and end up starting a patient that doesn't need it. So I think this talk is very, very important. And thank you so much, Dr. Zico, for pointing that out. Mulamba has a comment, and I don't know if Dr. Cassidy, you can attend to this one. They think it was just an acute Hep B. The first is for Edgar. The other bit I wanted to attend to. So Mulamba thinks this was just an acute Hep B. The question to you, Edgar, is, was this child breastfeeding?
The child was not breastfeeding.
Okay, thank you, Edgar. Child wasn't breastfeeding. Dr. Cassidy, would you like to comment on the what Mulamba has said? They said this was just an acute hepatitis B virus in the baby. ALT was 14.5. Pretty happy, positive Hep B surface antigen. So they are saying they think this is just an acute hepatitis B in the baby. ALT is 14.
Yeah, I think, again, as Dr. Vinikoor pointed out, we would expect to see a significantly higher ALT. This is acute hepatitis. And the baby would appear, have acute jaundice, to be demonstrative of an acute hepatitis B flare. So this presents more likely as chronic infection. And one of the key things that could have been done at the time of birth would have been vaccination and hepatitis B immunoglobulin, which can be used when the mother is hepatitis B surface antigen positive. Then you can help the baby to prevent acquisition of chronic hepatitis B by ensuring that the vaccine is given and the hepatitis B immunoglobulin is also provided to the child. So that's a key element of prevention of mother-to-child transmission for hepatitis B therapy. Thanks.
Okay, thank you so much. Do you have a question? Chatonda, do you want to read it out? Okay. Dr. Muya has a comment. It's a question.
The age of the patient.
2 years old.
The date of death.
I think that was just a typo, but they said 2 years old.
They said the date of death 2018.
18. How old are those people? 1 year? Okay, but I think they said 2 years. Maybe they meant, yeah, it was a typo. So 26. The child is 2 years old, right, Edgar?
Yes.
2 years old. Sorry. Thank you for that correction, Dr. Muya. Do we have a comment?
Do we know if the child was vaccinated? Because
so apparently
antibody as well.
So he says that the child was vaccinated 3 times according to the expanded program of immunization, which starts at 6 weeks. The pentavalent vaccine was given at the right time. So do you want to comment on that?
This child was completely asymptomatic. There's the other child that unfortunately passed away from complications. I mean, I think one of the things maybe that this child was vaccinated, and that's why they is a positive. But this is a surface antigen.
Surface antigen.
All right. So that then if you had a vaccinated child, you would have a surface antibody that would be positive, but you should not have a surface antigen that's positive. So in this case, it's not just evidence of prior immunization.
Okay. So there's a comment there. I can't see Chatonda. Please help me. So Michael is saying clearance in children is worse because the immune system is not yet mature like adults. So they will not have those very, very high LTs and ACs, but I'm sure he will comment on that. Zico is saying only about 5% of children will clear the infection, while over 95% of adults will clear the infection. So do we have statistics? I think those have been answered by Chilenje. Is there anything else? Do we have any other comments from the network? I know Dr. Mpeta is joining us from Dola. I see Chipata Central. Do we have a comment from Chipata Central? Chipata Central Hospital. Do you have a question? Please go ahead.
Yeah. We have a question. Can you hear me?
Yes, we can hear. Who's speaking, please?
Go ahead. Okay, this is Frederick Mwanza. I'm a clinical preceptor from Chipata Central Hospital. My question is about an otherwise healthy adult who we say walks into the hospital for just routine testing and he tests positive for hepatitis B, that is a surface antigen. Is there any need for us to say to a certain infection, do another test? How sensitive and specific is the surface antigen when it comes to hepatitis?
Thank you so much for that question. Congratulations, Chipata. Your IT is very good. We could zero in on the speaker. That's very, very good. I know that Michael gave the statistics to how sensitive this test is and why we should be very sure if it's positive. It's very likely that it's positive, but I guess do you want to talk about the sensitivity and specificity of the tests we are using in Zambia right now, our rapid tests?
Yes, sure. I can comment. Yeah, we discussed in the last hepatitis B session, which I believe is on Slack. What's the program?
Slack.
So you can review it. But essentially, it's about 90 to 95% sensitive, but it's more than 99% specific. So if someone gets a positive test, you do not need to confirm it again.
Yeah. Thank you so much, Michael. I know you mentioned we don't need a confirmatory test. I don't know if we have any questions for either Michael or Edgar. In case we have a lot of screens today. Don't ask me how I knew Chipata had the question without raising their hands. I just knew. I can tell from the body language when people are trying to actually ask a question. So, Michael, do you want to zero in on this case? I see Levi has also joined us. You are welcome. I see Lundazi. I can see Dr. Kanta, relaxed. If you have a question, just raise up your hand. Okay, hi, you're welcome. We have Dr. Mpeta. There's a question from Dola. Do you want to read that out for me, Francis, because I actually can't see? So unfortunately, I think you have another device playing in there, Dr. Mpeta, so I'm getting an echo. Chatonda, please read it for me. In case of HIV Hep B co-infection, what will worsen the prognosis of the other? Is it HIV or hepatitis B? This question is coming from on Noah, right? Or Noah, trust on Noah to pose such a question. So the question, I don't know if Dr. Cassidy, you want to take it or I throw it to Michael? So Michael, in addition to the three you need to zero in on, which one worsens the prognosis of the other? There must be some interesting studies of this on this, I know. Hepatitis B, hepatitis H, if you get hepatitis HIV, what happens there? What's the interaction of the two viruses?
Yes, sure. So having both is the worst case scenario, having both HIV and Hep B, in terms of mortality and in terms of liver disease. And then if you have to choose, no, you don't have to choose, but having hepatitis B alone is not as bad as having HIV alone, because remember, about half or even more than half of patients will never develop the complications and they'll never need the antivirals. So you might be one of those lucky patients who has hepatitis B that's inactive your whole life, in which case it's not so bad. But in HIV, we know without treatment, it always progresses. It's just a matter of how fast. It always progresses.
Thank you so much. Okay, so I see HIV worsens the prognosis of Hep B because you actually move on to need treatment, which you wouldn't if you were HIV negative. But I guess maybe this is what Ndola is trying to say, Dr. Mpeta and team. They're asking, could this child have been infected perinatally and the lack of prophylaxis and accelerated vaccination been attributed to why this child now has hepatitis B? They are saying, should we have done the vaccinations faster? I think Michael will touch that when he handles all the 3 questions. I think you can go into it.
Okay. Yeah, so the first point I wanted to make about this is actually a very wonderful case because it brings out a lot of issues, many. And some of the issues are really uncertain, so it's a very hard one to answer. But I think the first thing to take away is that this is common. Families with hepatitis B. We actually had, there was a woman who was tested in the Zambia, and she had 15 children, and 9 of them were also Hep B positive. And many of them came to Dr. Chunda and the pediatric department at UTH for review after Zambia. So I've seen families where there are many, many cases of positive hepatitis in the family. So the first thing that you all should take away from that is that when you have a client in front of you who has hepatitis, you should ask them to bring in their family for testing as well, because you might quickly be able to identify more cases. And if a person is not aware of their status, then they don't know to get the ALT test and the other workup. So they could be asymptomatically developing damages and even liver cancer. So it's important just to remember about testing the family. So then the second question, I think, was how do, so what was the scenario here? So this is a child who is 2 and they're coming out hepatitis B positive, and there is a history of immunization. So I want to comment that the Zambia study did hepatitis B testing from birth up to, I think it was age 55. And so they actually looked at children who were under 5, and only about 1% came out positive. And this is in the era where those children, almost all of them got vaccination according to the program. So we know that there are some children that are slipping through the cracks. And how does that happen? Well, I don't think it's failure of the vaccine, but I think it's a failure to provide the vaccine at birth. As Dr. Cassidy said, you can actually give a dose of hepatitis B vaccine at birth, a standalone vaccine, and that will give further protection to these exposed children. And so likely the mother of this child who is carrying hepatitis transmitted to the baby at the time of birth. And therefore, by the time the baby was brought for the jabs at 6 weeks, it was already too late. And so the immunization program couldn't prevent it at that point. So I think that's the scenario, and I think it is chronic hepatitis B because, as Dr. Cassidy said, there's no sign of active fever, jaundice, or high ALT, and so it's likely to be chronic form. Now, what would I do as far as management of the child, the mom, and the dad? What would I have done differently? Well, based upon the didactic session, what I would have done is to assess the labs. ALT, AST, platelets, and creatinine. We got almost all of them, and we saw that the child's ALT is normal as well. The AST is a bit high, but the ALT is normal. So in this case, I would not initiate antiviral therapy in the child, and I agree with the clinic, Dr. Chisuo, that I would not have initiated the child on any antivirals at this point. I would just be monitoring for high ALT. then what would I have done differently for the parents? So he said that the mom and the dad were symptomatic. So I'm going to assume that they probably had signs of cirrhosis, like ascites, swollen stomach, signs of chronic liver disease. If that's the case, then it's well justified to prescribe the medication. But it would have been helpful to see what the ALT was, because I think we're a bit, we feel we don't have all the information. But that being said, if the clients have symptomatic disease, which I'll assume means symptomatic liver disease, then yes, you can go ahead and prescribe the antivirals. So now the last question, I believe, was how do you prevent mother-to-child transmission of hepatitis B? So unfortunately, we do not have guidelines in Zambia. For example, there's really no guideline about testing in pregnancy. There's no guideline about the birth dose. The only thing that we do have is the regular EPI vaccination program beginning at 6 weeks. But given that I was asked, I would say that the most recommended next intervention is the birth dose. So if you're aware of a baby who's been exposed at birth to hepatitis B, you would want to give them an extra dose of the vaccine as soon as possible. At birth, or even at a week old, or even at 2 weeks old, just give them a dose to give them some extra protection until they reach 6 weeks. Then secondly, in the international settings, in Europe, in the US, in Asia, they do testing routinely of the pregnant women. They test them for hepatitis B. And some women, they do prescribe antivirals, meaning tenofovir. They'll prescribe it as a PMTCT approach. The way we used to prescribe, I don't know if you remember, before we had option B+, we used to prescribe ARVs just for pregnancy to prevent transmission. So there are some international recommendations around that, but it's really on a case-by-case basis. And I can't really tell you what to do because we don't really have any national policy for that as of yet. But I would just reassure you that these cases are quite rare. We're talking about maybe 5 in 1,000 babies that are being born with hepatitis B day and age. So the programs that we already have are doing quite a good job. I think Dr. Nsokolo had a comment, and he's also a hepatitis B expert.
Yeah, I can see what Dr. Nsokolo is saying. So when they did a study and they looked at 30 patients, over 50% actually had one first-degree relative, at least who had hepatitis B, whether it's the mom or the sibling. So testing family members is very important. And that's why everyone is saying, Edgar, this case is very eye-opening. So when you see one Hep B, you need to know that likely there's another one in the community with Hep B that's undiagnosed. And that's as evidenced by the case that Edgar has presented. It looks like this whole house has got Hep B. And the one in Zambia where one mom had 9 kids at home with hepatitis B. That data is actually very scary. So somebody's commenting that it also comes to index testing. Any comment on that? Maybe Dr. Nsokolo has joined us. I don't know if he can get onto audio. So people are suggesting you need to do index testing on these patients that come in with Hep B. I see Dr. Cassidy, you want to comment on the index testing and Hep B?
I can just say the same principles apply that we use for HIV index testing, namely that people who are related either by sexual connections or that's for horizontal transmission, or mother-child connections for vertical transmission, are likely to be to also have the same infection. One important point to note is that Hep B is much more likely to be shared among blood-borne transmission than HIV. For example, for healthcare workers, the incidence of Hep B transmission is 30%, whereas for hepatitis C it's 3%, and for HIV it's only 0.3%. So one must be very cautious in such scenarios as well. So inquiring to your index case about children and sexual contacts And of course, if they're a healthcare worker or if they're someone who's somehow exposed others to blood, would be all reasonable follow-up questions to ask.
Thank you so much. So I see a couple of questions. I'll try to answer some quickly because I met with Michael last week and we're talking about this. The question is, can Hep B vaccine used in children also work in adults? The only problem is the Hep B vaccine that we have on the ground, it's a pentavalent, the one that we give at 6 weeks. So, well, you don't want to give that to an adult, isn't it? You want only the Hep B component. So it can be bought quite easily if it's not available in the facility, which takes me back to Edgar's baby. When we say Hep B at birth, we are saying just the Hep B, please, not the pentavalent, because you don't need all of that and we only want to focus on Hep B. So if somebody is born to a Hep B mom, just get the isolated Hep B vaccine, not the whole cocktail of what that we have in the facilities. I hope that's helpful. But I don't know if Dr. Sokolo, Dr. Cassidy, you have this, Dr. Vinikoor, do we have any data on resistant strain of hepatitis B in our environment? There's a question from Chipata, because they are saying that something has been mentioned that there's potential for drug resistance. Do we have data on what's happening to our Hep B in Zambia?
Yes. I can just reassure everyone that tenofovir, which is the mainstay, the preferred drug, does not have resistance issues. The hepatitis B virus has not figured out how to resist it. So unlike HIV, where we're always obsessing over resistance and we're switching regimens, this is one example where it's easier because you don't have to worry. Even if the patient starts and stops and starts and stops, I've never seen a resistance case, and actually there's never been a true clinical failure due to tenofovir resistance ever reported in the world literature, including the Asian literature, where they have a lot of hepatitis B. So it's not something to worry about. And even if they do take lamivudine or emtricitabine, where your resistance can set in, you can switch them to tenofovir and you won't have problems.
Thanks. You're quick. I'm going to wrap up Edgar's case. So the recommendations is for the baby, we are going to watch and use ALT for monitoring. As for the parents, treatment has already been started. We will assume they had symptoms of hepatitis B, as you said. As for babies, we need to test mothers for Hep B. If mothers have Hep B, we give them just the hepatitis B vaccine at birth. Ideally, we should use the hepatitis B immunoglobulin. So that's available, but if they don't have it, the Hep B vaccine should prevent mother-to-child transmission of Hep B. I don't know if that's okay with you, Edgar. Do those recommendations sound okay with you?
Yes, they are okay, Doc. Thanks so much.
Yeah, no, thank you to you. Thank you to Michael. Thank you to Dr. Cassidy. Thank you to Bright Nsokolo, and thank you to everyone that joined us for this session. I can tell that people want more. Unfortunately, we need to wind up now. If there's any more questions, you can always send them in, and Chatonda will put all these, the talk that we had today on Slack, and we are hoping to engage Dr. Michael further on hepatitis B because it's clearly a huge, huge issue. So maybe you can tell people about Slack, Chatonda.
Hi, everyone. So Slack is a platform that we use to share everything that is presented in our ECHO sessions. That is the presentations from the specialists and the video recordings. So when you send your attendance registers, we get your email addresses from the attendance registers, and then we send you links to Slack to join. It's easy. If you have any challenges, please feel free to let me know, or Dr. Sombo, anyone else from the team here. Thank you.
Yeah, so I know we use Slack because it's linked to the Zoom platform, which is what we use for ECHO. There are questions on how people can join Slack. We'll answer these offline. Don't worry about that. And there are further questions on the e-antigen, but because we're not talking about that today, we'll answer it in further sessions when we have more advanced cases. Thank you so much, and it's a wrap.